Hello everybody, this is Professor Streb and I'm doing my Unit 2 recap and review voiceover. So this week we went through a lot of different topics, caring for the patient experiencing alterations in comfort, surgical patients, patients experiencing anemia, and then the assessment of hematological systems. The syllabus says you should go over the following things: care of the patient experiencing alteration in comfort, so we're talking about pain, caring for a surgical patient, the assessment of the hematological system, and then thinking about parts of the hematological system and when we talk about caring for patients experiencing anemia. So iron deficiency, B12 deficiency, sickle cell, and then folic acid deficiency. So to get started, we'll look at caring for the patient experiencing alterations in comfort. So we're basically talking about pain. So there's a lot of different things when we think about pain. We know that pain is very subjective, so whatever the patient tells us is exactly what we document. Pain is different for each and every one of us. I always say pain is in your head. I'm not taking away from pain, but without the receptors, the neurons, and that spinal cord that delivers the pain receptors up to the brain, you wouldn't experience pain. So very subjective. Pain is a very much motivator for people to seek care. Most of us don't go to the doctor unless there's something wrong, and pain is one of those big ones. So we know that pain is now considered one of the vital signs, and it's something that we have to ask and basically assess and check for each and every time we go in and talk to our patient. So when we think about pain assessment, how do we assess pain? Well, the first and foremost, easiest way of doing it is asking the patient, can you please tell me if you're experiencing pain on a scale of 1 to 10, or 0 to 10, 0 being no pain at all, 10 being the worst pain you've ever felt in your life. How would you describe your pain? So we want to get a description of the pain, but also the intensity, the location, the quality, and does it radiate? Those are things that we have to really worry about. When we're looking at patients, acute pain versus chronic pain, acute pain is something that typically is applicable to a immediate concern, something that wasn't there previously, but now kind of shows up, right? And like I said, how do we assess that? The best way to assess it is by asking. If you can assess by asking, if your patient can't talk, if they have some kind of neurological deficit, we could use the same thing we use for children, like the Wong-Baker face scale. We typically reserve that for children, but this just as effective as asking a patient who may not be able to communicate with you to point to the face that best represents their pain level that day. And then the last thing I'm going to say is when you're looking at chronic pain patients, assessing the impact that pain has on their life. Are they able to perform their activities of daily living? Or is the pain so great that it really, hampers their ability to function in life? These are the type of patients that we end up going to the pain management and treating for chronic pain. Pain management is multifaceted. There are lots of different interventions that can be used to help with pain. Pain management should include all of them. It should include the pharmaceutical type relief as well as the non-pharmaceutical therapies. We know that we have opioids, we have non-steroid anti-inflammatory drugs like Motrin and naproxen, things of that nature, Tylenol, aspirin. They all kind of work on some level to help combat pain. But we can't overlook some of the other things like distractions, turning on the TV, massage, light touch. It just kind of depends on what we're looking for. I've used a TENS unit in the past. This is one of the non-pharmacological therapies that your book is talking about, the transcutaneous electrical nerve stimulator or stimulation. You basically put like little EKG stickers on your body and it delivers a low voltage electrical current to the muscle that causes it to contract. And by causing it to contract, it will also cause it to release at some point. But what we need to know about is how do you use it? How do you put it on? How do you teach your patient to use it at the house? So things we need to talk about is you will apply the electrodes to the most painful areas, like it says there. You want to adjust the TENS unit until the patient experiences a sensation of pins and needle, and then kind of stop there. You don't want to go too far with it. And then if the patient is on a TENS unit and they're also taking pain medications, it's absolutely okay. You can use non-pharmacological therapies as well as medications to relieve your pain. There's absolutely nothing wrong with that at all. For the most part, it's just something you have to think about. When you're going through these chapters, think about what your role as a nurse is. What is it that you need to be paying attention to? When we think about pharmacological therapies and we think about pain management, we can deliver those multiple ways. We can give them the pain medication orally. It could be suppository rectally. It could be put on topically like lidocaine cream, sublingual, intravenous, or through inhalation. We can deliver these all kinds of ways. Injection is typically what we do. We'll administer via IV typically. Sometimes we'll go IM, but in a hospital setting, for the most part, if they have IV access, we'll give their pain medications via IV access. But what we worry about is something like opioids. It's not so much the drug itself that we're trying to test you over, but what is the safe medication administration things you have to worry about. So when you're giving somebody an opioid, we know that opioids can decrease the respiratory drive somewhat. So it's going to be a priority for you to constantly assess your patient. If they're on an oral medication, come back in 30 minutes and check. If they're on an IV, stay there with them and see how they react to it. If they're on some kind of drip, or if they're on an on-demand pump for pain medication, you need to pay attention to signs and symptoms that they might be overdosing. We know that a patient who appears drowsy and sleepy most of the day is probably being over-sedated. So that is something that we need to pay attention to in order to avoid our patient having respiratory complications as well. That's what I was just getting in here with the opioids. Opioids are analgesics. They are fantastic at relieving pain, especially in the moderate to severe levels. We're talking about your morphines, Dilaudid, and things of that nature. Opioids, like I said, they do act like opium, and this includes morphine, which we know morphine is what we typically give to patients in the hospital who are, experiencing that severe type pain. We can definitely go higher with other stuff. We use some of the drugs listed here, even do moderate sedation with sometimes. So we know that pain is subjective and people are different. People's thresholds are different. So tolerance, physical dependencies, these are things that I know people worry about. But in the hospital setting, in an acute care situation, we're not looking at these long-term use of opioids. So these are not things that are common with short-term use of opioids. So we're not going to worry about that so much in the hospital unless there was a medical history that kind of alluded to that in the first place. Side effects of these drugs are something you kind of need to pay attention to. We know that opioids also slow down the motility of your GI tract. So constipation is a huge side effect associated with the use of opioids, right? Because it increases smooth muscle tone and it decreases motility like I alluded to earlier. So we need to be sure that patients who are on opioids are using a stool softener like a Ducasate or something of that nature, that we're increasing their fluid intake and giving them a high fiber diet. So things you kind of have to pay attention to. When the nurse is caring for clients who are on like morphine via something like an epidural catheter, we know that people get epidural catheters for like chronic lower back pain. What we have to kind of pay attention to is understanding if the patient is developing numbness outside of that surgical site. So when a patient goes in to get epidural catheter, it could be for even if they're having a baby or they're having some kind of surgery, distal to that site, so somewhere in the lower body. It's not uncommon for them to use an epidural catheter to deliver that pain medication. But you need to start thinking about where that numbness is. Is it just in that one area or is it going other places? Just things to kind of keep in mind, because your job as a nurse is to be able to identify when there's something going wrong and alert the provider so they can take care of the situation. So that's pretty much with pain. There's not a lot to talk about with pain. Like I said, very subjective. You need to know how to assess it and what you can do about it. Other than that, there's not much more you're going to do for pain. Now, caring for a surgical patient, there are different parts of this. When you're thinking about caring for a surgical patient, we're talking about pre-op, intra-op, and post-op. You and I, as registered nurses, will typically get our patients pre-operative and we'll receive them post-operatively. The intra-op is typically reserved for your OR nurses. So when we're thinking about preoperatively and we're thinking about our patient, what they're doing, what is our role? So we know that clients have surgeries for multiple reasons, and these surgical procedures are separated into just lots and lots of categories. I won't get into all of those. They're not as important as some of the other stuff. But just know there are different types of surgery, and the type of surgery you're going in for kind of makes a difference, especially when you're talking about informed consent. You need to know what constructive type surgeries are versus curative. When we're talking about removing damaged tissues, if you have cancer, cutting that out. Diagnostic procedures, like you're going in to do a punch biopsy, or you're doing a colposcopy to see if you have cancer somewhere. Sometimes we do exploratory laparoscopic surgeries to see if there's, involvement of other organs or lymphatic system. And then there's things like emergency procedures, if you have a punctured lung, if you have a tension pneumothorax. So the reason I talk about these is just so you know when you're looking at informed consent, if the patient does not understand what the surgery is about, then it's going to be your responsibility to bring that up to the doctor. So preoperative care pretty much focuses on preparing the patient for surgery and ensuring safety. That is our big role. The care includes assessing the patient's knowledge and educational needs. This is right from the book there. And then implementing any kind of interventions needed before surgery to reduce their anxiety and complications and promote patient adherence to the treatment plan. During your assessment before surgery, you need to make sure you validate, clarify, and reinforce any information that was given by the surgical team. And if you identify any kind of problems that warrant further patient assessment or interventions before the procedure, then you need to contact the provider. And once you do all that, you want to get into the informed consent. So informed consent is a topic that a lot of people don't really understand. The surgeon, not the nurse, is responsible for providing that detailed information about the surgery. You and I can reinforce the teaching that has been done. We can clarify, we can give explanations if needed. But if the patient doesn't understand, then we need to call the surgeon back in. That is their job to answer questions about what they're going to do with the patient. As far as the nurse, what is it? What is it we do? What are some of the situations that we might face that, that are kind of outside of the box thinking? That's where NCLEX is going to test you on. So if we're thinking about, what's going on, if the client has questions about potential surgical complications, you and I don't answer that because I didn't go to school for 12 years and didn't go to medical school. It's not my role. The nurse's legal role is just obtaining informed consent. You're witnessing the client's signature. That is your job. You're saying, do you have any questions? They say no. They sign it. You're good to go. Clients going for all kinds of surgery. So if a client's going in for an invasive procedure, you must get informed consent always, right? Why? Because the patient needs to understand exactly what's happening before we go in and do something. They have every right to say no to any surgery you want to do. It is their life, their body, their choice for sure. So, but sometimes you'll get a patient who comes in for a life-threatening situation and they can't consent, right? Because they are asleep or, they are unconscious, whatever the case may be. So in a life-threatening situation, when consent is desired, but not essential, we should still attempt to contact whoever their power of attorney is. If we can get them to come in and sign it, that's even better. If their family is out of state, but they are on the power of attorney, verbal consent is fine as well. We can get verbal consent from their power of attorney, and that's what we always want to try to do first. Clients who are unable to sign because they're unable to write, or maybe they're unable to read, or they're just unable to do anything because they're paralyzed or whatever, we can get them to sign an X versus their actual name, but that must be witnessed by at least 2 people in order to validate that. But with informed consent, just like any other patient, making sure you're checking for patient identifiers is huge. Make sure the ID band is in place and consent is signed before your patient goes to surgery, because the last thing we want to do is have a sentinel event or a wrong site surgery. Those are going to just not good. All right. Pre-op nursing, there's a lot going on preoperatively. The main thing that we're looking for, as a nurse, we just need to look at all the stuff going on. So if you look here on the slide, it says inform, notify, administer, give, raise. This is something I just came up with. So we want to inform the surgeon if there's any kind of abnormal lab values. Of course, the doctor is going to go in there and look eventually, but we're there with the patient for hours. The doctor is typically in surgery doing surgery on multiple patients back to back to back to back. So our job as a nurse in the preoperative role is to look at everything. If we receive results, preoperative blood work on a patient who's scheduled for surgery, be able to identify on a test, and especially on NCLEX and things of that nature, which of these labs presents a problem. Yeah, hypokalemia. We know that could have issues with muscle, especially specifically cardiac. Thrombocytopenia, if the patient's having clotting problems. If you have an abnormal INR that is one way or the other. Think about like hemoglobin hematocrit. These are also things that we need to worry about. If you have a hemoglobin of 8, that means we're not perfusing correctly. We don't have enough oxygen carrying capacity in the blood to really meet the demands of the patient's the organ's demands. So those are things we need to talk to our provider before they go into surgery, because they might need a blood transfusion first. Our other job is to take care of personal items. I can't tell you how many times my mother, before she died, she'd go to surgery and they'd lose her dentures. I don't know if you know how much teeth cost, but they're expensive. Same as hearing aids. So we need to notify the OR team where kind of what's going on. We know that patients can leave and go to the OR with their hearing aids in so they can still hear, but we just need to make sure that the OR nurse is aware of something like that. Other things to kind of keep in your mind here is when we're starting to give medications, right? Especially for a patient who has some pre-op medications, things that might cause a little bit of sedation, if you will. So if a patient's scheduled for surgery, we need to make sure we don't give them any kind of medication that would cause them drowsiness or affect their cognitive ability prior to them signing informed consent. Once we do that, the patient can't consent, so we'd have to stop the surgery. But once we give a medication that might cause some dizziness or cause some kind of level of consciousness changes, we need to make sure safety is our priority. Make sure the bed is in the lowest position. Make sure we raise up the side rails. Things like that. Place the client's call light within easy reach. We don't want our patient getting out of bed because we medicated them with something that could cause them to be an increased fall risk. So a lot of this is going to be dealing with patient safety. And then another thing that I could think about is when you're kind of getting with your patient. You think about a patient who might have been admitted and they're coming in, they're going to have surgery. You're trying to prepare your patient. You're trying to get them ready to transport to the surgical site. What is your role there? You want to check for stuff. So you want, like I said, notify the OR where the hearing aids are, if they have a wedding band that was given to the spouse, anything like that. Make sure you're overly communicating. And then see what medications were given and not given. It just kind of depends. Do we need to give certain medications before they go to surgery? I think about something like insulin. Would we want to give it insulin before they went to surgery? Probably not, because they've been NPO for the last 12 hours. And they're not going to eat while they're in surgery. So, you have to pay attention to things. Just because you have an order on your MAR doesn't mean you need to give that medication. You have to use your nursing judgment. So these are some of the things I think about preoperatively where I've seen people kind of make mistakes. And you just have to keep thinking about patient safety, thinking about exactly what's going on. Think about the situation. It's not simple enough just to read. We are nurses. We are not technicians. We don't just look at orders and do. We question every order. We look at the validity of them. We make sure that the medication is making sense. Would you ever give an antihypertensive medication to a patient who has a blood pressure of 80/40? Absolutely not. Same thing with a patient who's going to surgery. There are certain medications we're not going to give. All right. Lastly, make sure you talk about previous surgeries. If you have a patient who's had surgery before, or they had a family member who has had surgery before, and then they had some kind of reaction to anesthesia medication prior to their last surgery or during their last surgery, that's something you'd want to promptly notify the anesthesia provider about. And it could be something simple, spiking fevers during a previous surgery. That could be indicative of the patient having a reaction to anesthesia. So, pay attention to what your patient says. If it sounds abnormal, you should probably report it to somebody at that moment. All right, preoperative teaching just keeps going on and on. I can't stress to you enough that in the preoperative phase, we're worried about patient safety, identifying concerns that might become problematic during surgery, and then thinking about the teaching. The best time to teach a patient is before they go to surgery. Once they come out of surgery, they're going to be sedated, they're going to have pain, they're going to have other issues. If we can address those concerns and those needs first, the likelihood of the patient retaining that information is increased drastically. All right. I think I kind of covered everything I want to talk about here. when you're looking at your patient, think about what kind of surgery they're having and what they're going to have to focus on once they come out. Just like we talked about with immobility, if your patient is going to have an amputation, positioning, things like that. If your patient's laying flat for a while, it just kind of depends on what's going on. If the patient's sitting still in bed, not able to get up, we still want them to do some kind of exercises to promote venous return. So we will want our patients to do those ankle flexion exercises after surgery. We do want them kind of moving in bed the best they can, raising their legs up off the bed if applicable. Make sure when they come back, we're doing the deep breathing, the coughing, the ambulating, the pain control. We give them the incentive spirometer to help them expand their lungs and open those alveolar spaces so we get better gas exchange. These are things that you have to be talking about. Talk about the need to cough and deep breathe at least 5 to 10 times every hour. Tell them when you're watching TV, when the commercial comes on, use your incentive spirometer. Make sure that you stress the importance of exercising the extremities. We don't want to get a DVT that turns into pulmonary embolism. Those are things that can be prevented by us doing our job. So inform the client about the things they need to do to prevent clot formation and things of that nature. Put on the anti-embolism stockings. Put on the SCDs, the sequential compression devices. The low molecular weight heparin, like whatever the doctor orders for them. We're gonna use that as well. And then lastly, I would say if the patient has a drain and they're going to go home with a drain, or if they have tubes, or if anything is going to be in them for a little while, we need to make sure that if they have something like a JP drain, that they understand how to squeeze it and make sure that it is squeezed before they close it so it creates that negative pressure and actually causes some suction. If they go home with, a tube in them, do they know how to drain it? Do they know how to use it correctly? Do they know how to wash it, rotate it, change it, access it? Those are things you need to be able to do beforehand. And then talk about something as simple as what they can eat when they come back. We know that when people start progressing out of surgery, we start as tolerated. That usually means we go with clear liquid diet first, and then we work our way up. Our intraoperative nursing, there's not a lot you're going to do intraoperatively. This is where the OR nurse does their thing. So I won't minimize this very much, but know that while they're in the surgery, you can look at this. You can go back in the book and look as well. That they're going to be in a certain position, so they have the increased risk for hypothermia because it's so cold in there. They have the increased risk for peripheral circulation issues and the clotting. So we need to make sure that we're aware of that. They're not breathing deep while they're in there. So when they get back, we just need to think about intraoperatively as what's going on and what we need to do when they come out. All right. So now when you get to the PACU or the Post-Anesthesia Care Unit, most of you won't be working in the PACU right away, but you never know. You can apply at Methodist and they'll put you right in the PACU if that's something you want to do. When we think about the PACU, when we think about post-anesthesia care, that's exactly what we're talking about. The patient just was weaned off anesthesia. So this puts them at an increased risk for a lot of things. When you're assessing a client who was admitted to the PACU and they've had general anesthesia, we need to start thinking about what their respiratory rate is. Immediate assessment is always going to be ABCs. It's super essential that you're looking at airway, breathing, and circulation. That's not new to you as an LVN and being in the RN program. You already know this. But look for a patent airway. Look for characteristics that the airway is not open. That could be wheezing or things of that nature. Look at depth and respirations, depth and rate of respirations. If you're breathing 40 times a minute, that probably means you're not getting good gas exchange. On the opposite side, if you're only breathing 6 to 8 times a minute, you're not perfusing correctly. We know that opioids, especially when we think about anesthesia being administered that way, general anesthesia for sure, it can decrease their respiratory rate. So if they are not breathing correctly and they have decreased, breath sounds in the bases, we need to try to do something. The first thing we're going to do is try to wake the patient up. Hey, Mr. Smith, I need you to wake up. Do a little sternal rub. If that doesn't work, we might need to bring some Narcan on board, right? That's what we give somebody who is having an opioid overdose, and that's exactly what this would be if they're not breathing correctly. So make sure that you're trying to arouse your patient. You're trying to increase their O2 sats if they are down. That is what you're going to worry about in the post-anesthesia care unit. We're also going to look for signs and symptoms of bleeding. Every one of us know that signs and symptoms of hypovolemic shock or hypovolemia is going to be exactly what it sounds like. You have low volume. Low volume leads to hypotension or low blood pressure. You're always going to be tachycardic, tachypnic, because your body's trying to compensate. If you start noticing patients manifesting with any of these signs and symptoms, then you need to call the surgeon, right away. So like I said, these are, even for little simple things, it could be as simple as a wrist being broken and they had regional anesthesia. That's cool. No worries at all. But what you always want to do first is assess the client's airway, breathing, and circulation, because anytime they get any type of anesthesia, it can still cause an issue. Or when you're working on bones and you're doing surgery, you could throw a clot, and that too can get into your respiratory system, in the pulmonary tree, in the vascular system, and that could cause a pulmonary embolism. So these are the things you need to kind of worry about. Lastly, it's kind of interesting, post-op patients who are on any kind of corticosteroids increases the risk of that adhesion of the wound, so we have to worry about, is the wound going to open back up? Post-operative, kind of the same story we just talked about. In the immediate PACU, we're more worried about the breathing, airway, breathing, circulation, because of just how recently they were on some kind of general anesthesia. Post-operative period is after the surgery is completed, they're out of the PACU, and now they're, maybe on, a recovery floor. It just depends on what they can go straight back to medical surgical. It just depends on where they need to go. It might be ICU, but we're going to assume they're coming back to a medical surgical floor, or a post-surgical floor, and that's where we're going to have them at. So when you get the patient back to your, if they had ambulatory surgery where they're the same day surgery and they're going to go home, we know that we're going to start planning the post-op discharge and teaching instructions right away. Like I said, we've already talked about it preoperatively. You want to talk to your patient about what they should be doing and teaching, but in the post-operative phase, we're also going to reiterate and strengthen the teaching we already had. Like I alluded to, if a patient's going home with some kind of drain, make sure they know how to use it. Have them do a return demonstration on what they need to do in order to make that thing work. Because what you don't want is the patient to go home and have an issue because you failed to do your job, which is in teaching them. And at least, even if you're not teaching, making sure you're assessing their knowledge so you can call somebody else to teach them if need be. So look, like I said, look here on this and kind of pay attention to what's going on. There's a lot of good stuff. We are going to worry about pain, of course. We're going to worry about, that breathing, airway, breathing, circulation always. We're going to look at vital signs constantly. Vital signs are going to give you the best indication of your, respiratory and cardiac status. If we see decreases in the blood pressure that go super low, that's probably a sign of bleeding. When you're looking at test questions, look at timing. If it's immediate post-op, we're probably more worried about breathing, airway, circulation type stuff. If it's 2 days post-op, we're probably more worried about fevers and signs and symptoms of infection. So discharge teaching, go back here and look at these again. Make sure that the patient knows what's going on and when you should tell the patient to contact their doctor. Like I said, if they go home and their blood pressure keeps going down, it's probably important for them to go be seen at the emergency room. Same as you. If I see the blood pressure going down and it's consistently going down, your book says 28 millimeters of mercury or greater, then that is the time to call the physician, the surgeon, and let them come back in and check to make sure there's not something going wrong. And then all indwelling catheters should be discontinued day 1, latest day 2. We don't want to keep those in very long, so just something to think about. All right, so that's pretty much with the pre, intra, and post-operative patients. A lot of safety, a lot of teaching. That's where you need to focus the majority of your attention, is understanding what the safety features are you need to worry about. When I say safety, that also promotes quality patient outcomes like the deep breathing, the ambulation early, the sequential compression devices, the antibiotics, things of that nature. And then post-operative is going to be a lot of the same thing, assessing for signs and symptoms of issues associated with airway, breathing, circulation, maybe infection at some point, and then what kind of teaching the patient needs to do. All right. The last part that we talk about in this unit, for Unit 2, is going to be the assessment of the hematological system. We're referring to the oxygenation and tissue perfusion. That's exactly what we're talking about. These are the components of the blood that really help us perfuse our body. So we know that red blood cells contain hemoglobin and hematocrit, and the hemoglobin is pretty much what transports oxygen, right? It's where oxygen is transported to the cells, And in the lungs, it's where we have the gas exchange, where we trade out the carbon dioxide for oxygen, and then your lungs breathe out the carbon dioxide, and then we're good to go. So it's imperative. I can't stress this enough, from here until the day you stop ever going to nursing school again and quit being a nurse. You need to know lab values. Do you need to know every single lab value 100%? Ideally, yes. But as long as you have a decent idea of the range, you're probably going to be okay. So be sure you understand what it looks like. There's no getting around that. If you don't know lab values, you're going to pick wrong answers just because you don't know what they are. So when you are a nurse, when you're looking at these patients and you're doing an assessment of somebody's hematological system, think about priority. Think about what makes a difference with these patients. Do you have sickle cell? If you have sickle cell, that is something that we need to know about. If you are vegan like myself and you don't eat meat, things like that, that puts me at the increased risk for iron, maybe iron deficiency. I can be B12 deficient as well, because B12 is something you get by eating basically manure that we get from animal products, right? So kind of pay attention to some of the when I say assessment data also means everything you get from their history and physical. Don't lose sight of that as well. And like I said, make sure you look at their dietary restrictions, because that does play a big role in hematological systems. And then there are your RBC levels on the bottom there. All right, when you have a patient who has anemia, and anemia, don't forget, is just a decrease in the RBCs, specifically your hemoglobin and hematocrit. It's not a disease per se, but more of a sign and symptom that something's going wrong, right? If you have bleeding, my mother used to have GI issues. She had diverticulosis, and then she'd eat certain things and have a flare-up. I knew when she had a problem. I knew when she was bleeding internally, because I talked to her on the phone and she sounded loopy. Her mental status was altered for sure. And I would tell her, it's time for you to call an ambulance because you need to go in and get a blood transfusion. Every single time I was right. Her hemoglobin would be down in like the 8s, hematocrit probably in the low 20s. So when we're thinking about anemia, we're thinking about the inability to perfuse your body. One of the earliest signs and symptoms of that lack of perfusion, especially, is to your brain, and that's going to be that altered mental status. This is another example where you have to know lab values. If you don't know that hemoglobin is between, I'll let you go back and look at the lab values. What I always think of is the same thing. When it's lower than a certain number, typically on an exam, if it's less than 10, it's going to be problematic. So that's usually where I keep my mind. Even in real life, when I'm working in the ER, less than 10, more than 10, we don't ever transfuse. It's usually less than 8 when we transfuse. But for testing purposes, if it's less than double digits, you definitely have an issue. Yeah, and then make sure you know what PT and PTT and INR are. These are, when you think about your proton times, you're thinking about clotting. Is the patient able to clot or not? And that really makes a difference if we're talking about somebody who's bleeding out internally, or if they have, it could be surgery or whatever. You need to kind of pay attention to their clotting times. All right, iron deficiency anemia. I think you can kind of allude to what causes iron deficiency. It's when your body doesn't have enough iron to produce hemoglobin. So when you don't have enough iron to produce the hemoglobin, your H&H is going to be low automatically. So by not consuming enough iron, that's one way. Or if your body's losing too much iron, that could be a problem as well. Like I said, for me, it depends on diet as well. You might not get enough iron, so you might have to take supplements. Signs and symptoms of this might be extreme weight, like extreme fatigue, weakness, pale skin. Once again, if you're not perfusing your organs, these kind of make sense. This is the pathophysiology part that you would kind of have to think about. You might also even see the fissures at the corners of the mouth. That is another telltale sign that somebody's having iron deficiency anemia. All right, vitamin B12 is another deficiency that we talk about as anemia. This is when you don't have healthy red blood cells, and it's due to lower than normal amounts of certain vitamins. Specifically, in this case, vitamin B12, also vitamin C. We know, like I said, vitamin B12 is something that we produce ourselves and that we excrete through our fecal matter. So do animals. So if you're not eating other animals, you might have a vitamin B12 deficiency, but there are other sources you can get from it. You can get it from nutritional yeast, other sources. However, that is probably the most common thing. Vitamin B12 injections are something that is ordered quite frequently when people have vitamin deficiency because of the issues associated with it. And then some of the quick signs and symptoms would be that smooth, beefy red tongue, and then having that numbness and tingling of the hands, muscle weakness, and then problems walking. The last one we're going to talk about in this is sickle cell disease. And sickle cell is something that you're born with, so hereditary. Typically, you'll see sickle cell disease in African American populations, so that is a disease process that more familiar in that certain demographic. What is sickle cell disease? It's just your hemoglobin that is sickler, like a sickle, a moon-shaped crescent, if you will. It's not round, and what the problem is the irregular shape of the hemoglobin causes it to adhere to other ones. They cut each other, they get a little sticky and rigid, and they start to clump together and clog. So once your hemoglobin starts to get very sticky and start adhering to one another, you're going to get a blockage of your artery. And when you get a blockage of your artery, what happens? You get decreased blood flow. When you get decreased blood flow, you get decreased oxygenation to the distal user. So it's not uncommon for these patients to come into the ER complaining of severe pain, really anywhere in the body. What we're going to do as nurses is kind of limited, but what we're going to do is encourage fluid intake, because if we can decrease the viscosity of the blood, make the volume in your blood vessels greater, it decreases, it increases blood flow, and it makes the clots not near as problematic. They're also going to have an issue with staying warm. So we need to make sure we keep them warm, avoid external blood pressure monitoring, and then make sure we do pain medication.